Thanks for having me. There we go. There we go. So thanks for having me. Just for those of you who aren't from South Carolina, so I'm a faculty member at the Medical University of South Carolina. And we actually been fortunate enough to have a very gracious patient help establish a sarcoidosis center there. And so the goal for the talk today is really just to go through why sarcoidosis is different, talk a little bit about the evaluation and physiology. I tried to shorten this a little bit from an hour-long talk, so hopefully we'll get through everything, but I may skip over some of the slides that maybe are less pertinent, kind of like that one. So we'll talk about sarcoidosis in the modern area. And really, my motivation for giving this talk to you guys is basically to increase awareness about sarcoidosis. So hopefully at the end, you will all be deputized to be able to educate other people about sarcoidosis. And we'll talk a little bit about specifically lung function testing in sarcoidosis and why it's a little bit of a different disease compared to a lot of systemic diseases. So obviously, in a perfect world, this would be clean and precise. In reality, it may end up being a little bit more like my daughter after her first birthday. And I always now have to update it with a current picture because you can tell how long I've been using her old picture when she was 1 year old. So the honest answer of how do you get sarcoidosis is we don't know. We do have good evidence, though, that there's some environmental trigger that patients get exposed to that leads to an abnormal immune response. And we think there's a genetic predisposition in the immune system. And the result of that is you get basically a Th1 polarized immune response that leads to granuloma formation. And actually, a lot of the basic science behind that process is well understood. What we still really don't know, though, is why some patients go on to have remitting disease, which happens in 60% of people, and about 30 to 40% will end up with chronic disease and bad scarring in the lungs. And there's still a lot of ongoing studies looking at, what are possible environmental triggers and what the actual genetic mutations may be associated with it. So, as with most things, when you don't have somebody in custody, everybody's a suspect. So the things that we've looked into really are unlimited. So we do know moldy environments, insecticide exposures associated with it, lots of dust, inorganic and organic, as well as infectious causes. So in Japan, if you actually look at biopsy samples from sarcoid patients, almost 60% of them will have Propionibacterium acnes DNA there, which is the same bacteria that causes acne. Here in the US, it tends to be mycobacterial DNA, but having DNA doesn't necessarily mean that there's an active infection. So we can't directly link the presence of that DNA to causing the disease. And while I tell patients sarcoidosis is not truly an inherited disease, so it's not like sickle cell where you can follow it down through generations, we do know that if you have sarcoidosis, your immediate family member is 4 to 5 times more likely to have sarcoidosis. But we have some twin studies showing that it's about a 66% heritability. If you compare that to sickle cell, it's upwards of 80 and 90%. So classically, it's still considered a rare disease, which for those of you who aren't aware, Congress actually defines that, and the cutoff is 200,000 people in the US. So some of the older studies are consistent with it being a rare disease, but a more recent study actually suggested it could be as high as 1 million people in the US. And we at least know if you just look at people 18 to 55 years old with insurance, 185,000 of those people seek healthcare for sarcoid in a year. So I think the number is actually much higher than 200,000, but we don't have really good data compared to countries like Sweden, where they actually have national population registries. So they can go in and say, we know exactly how many sarcoid patients we have. And so their reported prevalence is about 215 per 100,000. The other unique thing about sarcoidosis is there's a lot of heterogeneity across different populations. So if you look at the MUSC column in the middle, we're about 65% Black and 35% white. Compare that to the cohort at UCSF, which is San Francisco, they're 77% white. Minnesota is also about 70% white. And the reason I throw this up there is because it's a really common misconception, one, that white people can't get sarcoidosis, but we know that it's definitely more common in Black patients. So if you take 100 Black people, more of those people are going to have sarcoid than 100 white people. But the total number of sarcoid patients in the US, purely based on our population distribution, there's still more white people in the country with sarcoidosis. And unfortunately, Black patients are also more likely to require treatment, have more organ involvement, and higher mortality overall. I'm actually on the Foundation for Sarcoidosis Research has a Women of Color committee now, and our sole purpose is really to increase awareness among Black females about the disease and help more people understand about it and be sure they get the care they need. And how you present depends on where you're from as well. So here in the US, we typically see more advanced pulmonary sarcoidosis, more lupus pernio, which is a disfiguring type of skin lesion that sarcoid patients can get here. And so the argument for that sort of environment and racial interaction holds true even here in South Carolina. So this is an older study from 2008, I believe it was. And what they did is basically look at the different geographic regions and figure out the populations overall in those regions, and then compare population differences to hospitalization rates for sarcoidosis. And so what they found was that if you look at the low country along the coast here in South Carolina, there are way more Black patients being hospitalized for sarcoidosis that you can't account for just based on there being more Black patients who live along the coast. And so, one of the ideas is that maybe because of the salty, humid environment, there's different bacteria here that, Blacks may be more likely to have a reaction to compared to whites, which is the higher prevalence. But at this point, it's a lot of theory and not much solid data. So when it comes specifically to pulmonary sarcoidosis, up to 60% of people can be asymptomatic. About half of patients may have some non-specific respiratory symptoms, shortness of breath, dry cough, some chest pain. The most common symptom that we see, though, is fatigue. So 80% of sarcoid patients will have fatigue. It's more common in sarcoidosis than IPF, which is idiopathic pulmonary fibrosis. And actually, if you compare quality of life to pulmonary function testing versus the report of fatigue, fatigue is a better indicator of quality of life overall than pulmonary function testing is. And certainly having fatigue can impact how well somebody does on their PFTs. So our respiratory therapists here know well that, if one of my patients says, hey, I'm just not doing good, that we're not going to expect, their PFTs to be as good. And that's not necessarily because their lung disease is worse. It may just be that they've just got profound fatigue that day from sarcoid. And when you listen to these patients' lungs, 99% of the time it's normal. If they've got really advanced scarring, sometimes they'll have bronchiectasis and they'll have, colonization with bacteria, productive cough. And in those people, you may hear some musical rhonchi. Occasionally with some proximal airway disease, you'll hear wheezing. But again, the vast majority of people, their respiratory exam is normal. And so it's well known that while 90% of patients have lung involvement, it can really affect any organ system in the body. And the tricky thing about managing sarcoidosis is that actually the lungs aren't often the highest priority. So 50% of people in the large access study from 2001 had extrapulmonary sarcoidosis. If you compare that to MUSC, almost 75% of our patients have sarcoid in another organ. And there is this idea of having dangerous organ involvement in sarcoid. So that includes your eyes, your brain, your heart, your kidneys, and high calcium levels. And the reason we call those dangerous, quote unquote, is that if you allow active inflammation to continue in those organs, it can lead to irreversible damage and long-term complications. So, the most obvious one would be if you have inflammation in your eyes from sarcoid that's not treated, eventually that can lead to blindness, which nobody wants. And so while there's a lot that can happen in sarcoid, the overall prognosis is actually pretty good. So, less than 5% of sarcoid patients will die from their disease. The vast majority of those who do die from complications of scarring in the lungs from their sarcoid. So Bernie Mac is probably one of the most famous people that most people know about who've died from sarcoid, and he actually died from a bad pneumonia he got because he had a lot of scarring. A smaller percentage of patients will have mortality rates increase that are due to cardiac and neurologic involvement. Oftentimes, a lot of those patients never knew they had sarcoidosis, and their initial presentation is sudden cardiac death. But once people get diagnosed with heart involvement, for example, typically they do well and don't have issues or increased mortality. So overall, 60% of patients with sarcoidosis, the disease goes away on its own by 5 years. But like I was saying earlier, about 30% of people will end up with chronic disease. And really the biggest priority when you're seeing a sarcoid patient is to be sure that they've had dangerous organ screening. Because if you miss that, it can really result in bad outcomes for people. So we'll talk about the new ATS diagnosis and evaluation guidelines. I was an author on that, and it was an interesting process. I'll say I still consider myself young, so I'm humbled they included me. And then we'll talk about pulmonary testing. Typically in these people, I only do spirometry and DLCO. I don't really find lung volumes to be that helpful very often. We do 6-minute walk testing, and then every patient will have at least a chest x-ray, and a lot of times they'll have a CT as well. For extrapulmonary organ screening, everybody gets labs: creatinine, calcium, alkaline phosphatase or liver function testing panel, a complete blood cell count, and then everybody gets sent for an eye exam. Even without any eye symptoms, you can actually still have inflammation in the posterior compartment. So they need an eye exam whether they have symptoms or not. And everybody gets at least an EKG. The Heart Rhythm Society guidelines actually suggested getting an EKG and an echocardiogram. Practice really varies a lot across different centers. I actually do get echocardiograms in all my patients, in part because I want to screen for cardiac involvement, but also want to look for what's called pulmonary hypertension, which can happen in sarcoidosis. So historically, we're not very good at this. The first visit with a physician leads to a diagnosis of sarcoid in only 15% of the time. And typically it can take about 6 months for about half of patients to get a diagnosis. And so you can imagine this initial process for a lot of patients is really frustrating. There's really 3 things you need to diagnose sarcoidosis. The patient has to have compatible clinical presentation, so symptoms, imaging, lab work, that sort of thing. You have to get a biopsy, if possible, that shows non-caseating granulomas, which is basically just a description of the collection of immune cells on the pathology slide. And then you have to exclude other diseases. One of the things that's sort of tricky is trying to define what a sufficient amount of effort is to exclude other causes. In general, the biggest things we worry about are unusual infections and cancer. And so if you get a biopsy from, say, a lymph node that shows granulomas and there's no evidence of cancer, then most people would consider that sufficient for ruling out other causes. So like I was saying earlier, some common misconceptions are, that more Black people have sarcoidosis than white people. So like I said, the prevalence of sarcoidosis in the Black population is higher, but still the total number of sarcoidosis patients in the US are mostly white. Having stage 4 sarcoidosis means you're going to die. It's definitely not true. So scatting stages were actually developed by a guy over in Europe back in the 60s, and he was a radiologist. And what he did is figure out that, hey, depending on what the pattern is on their x-ray, I can actually predict the likelihood that their X-ray is going to be normal in 2 years. And so stage 1 is just enlarged lymph nodes. 2, they have enlarged lymph nodes and lung involvement. 3, the lymph nodes are gone down in size, but they still have lung involvement. And 4, they have scarring. And the frustrating thing about this from a physician standpoint is that, patients oftentimes associate scatting stages with cancer stages. And so I always tell them, I have a lot of stage 4 patients who are not on treatment, who are doing everything they want to do and aren't limited at all. Whereas I have a lot of stage 1 patients who are on 2 or 3 medications to control their symptoms and are much more symptomatic. And even patients who present with stage 4 disease, 15 years later, 78% of them are still going to be alive. And so what Dr. Scatting found was that patients with stage 1 disease, almost up to 90% of those people will have normal X-rays 2 years later. And then as you moved up in stages, it was less likely that you're going to have normal X-ray 2 years later. And so it's really prognostic of the X-ray and not necessarily of the patient. So why do patients with sarcoidosis get short of breath? So, obviously you can have parenchymal lung disease that causes reduced lung function. You can have actually respiratory muscle involvement where you actually get granulomatous inflammation in the muscles itself. You can get cardiac sarcoidosis leading to heart failure or arrhythmias. You can get pulmonary hypertension, which really tends to drive dyspnea once patients develop that. And even just having a lot of stress and fatigue can cause shortness of breath in patients. Certainly, obesity, we know that that's a risk factor for developing sarcoidosis, especially among Black women, and deconditioning can be a huge issue. And so, a lot of times what happens in these patients is they get short of breath, they do less because being short of breath is uncomfortable. They get more out of shape, so they do less, and they end up getting caught in this cycle of, just continuing to do less, getting more out of shape, more shortness of breath. And so I always tell people, we'll talk about this later, hopefully, if we have time, exercise is good. Pulmonary rehab for everybody, in my opinion. It's a hugely beneficial program for these patients. So the impacts of sarcoidosis on PFTs really depends on the degree of lung involvement, which is kind of common sense. 40 to 80% of patients with parenchymal lung disease will have abnormal PFTs. But even, 20% of patients who don't have obvious lung disease, but do have enlarged lymph nodes may have abnormalities on spirometry or DLCO. The most common thing we'll see is a reduction in DLCO. The next most common is a reduction in FVC, followed by obstruction. And just for some examples of what sarcoid can do to your lungs. So the image on the left of the screen is just a good example of what we call perilymphatic nodules. So these tiny little lumpy, bumpy areas extending out towards the periphery are all just small little areas of granulomatous inflammation. So that's one end of the spectrum. The other end is the other picture where the patient has had inflammation for a while that's caused a lot of architectural distortion and even a large cavity in the right upper lung zone. And this is sort of a classic X-ray for what we call fibrocystic sarcoidosis. So an obstructive pattern on PFTs, we'll see it in about 15% of patients. Oftentimes it'll be related to either upper airway involvement. Obviously with that, if you look at their flow volume loop, they'll have a truncated inspiratory or expiratory limb. A lot of times they may have proximal airway fibrosis. So you can get something called endobronchial sarcoid. So instead of it being farther out in the lung, right where the airways branch out, they'll get a lot of inflammation in those areas and the airways actually will get narrowed. The other thing that can happen is they'll actually get lymph nodes that are so huge, the lymph nodes can start to compress the airways. And certainly as you start to move out into the airway, you can actually get involvement of the respiratory bronchioles farther out that can be proximal enough to result in obstruction. And then you can just get air trapping for more peripheral small airways disease. Typically when they have obstruction, they will have wheezing. A lot of times they won't get better with bronchodilator challenge. The caveat to that is that about 20% of sarcoid patients will have reactive airway disease. And it's unclear though if that's actually related in any way to their sarcoidosis, or if we actually overestimate the number of patients who have reactive airway disease based on a methacholine challenge test, because the airways at baseline in people within a bronchial sarcoid is always smaller. And so it takes a smaller change for them to have a significant response. So some people actually think that 20% number is closer to 5 to 10% in reality. So when we see restriction on PFTs, oftentimes it'll be related to honeycombing fibrosis and bronchial distortion. Unfortunately, this is what we typically follow in clinical trials. I think that's part of the reason that we have a lot of negative clinical trials out there, because oftentimes you'll start people on therapy, they'll feel significantly better, but their FVC won't go up by 10% or more. And so it's a hard thing to follow in a lot of patients as a clinical endpoint and a research endpoint. Historically, a lot of people used to look at CTs like this and say, oh, you've got burnt out sarcoidosis, you don't need any treatment. However, more recently, especially in Europe, where they don't have to worry about insurance companies and they can do PET scans when they want to, studies have found that actually 75% of patients will have active inflammation from sarcoid associated with these areas of scarring and will benefit from treatment. So we tend to treat a lot more people with fibrotic sarcoidosis now than we did 10 or 20 years ago. So when we say reduced diffusing capacity, it's tricky. Obviously that can be affected by a lot of different things. Certainly patients who have scarring usually have a reduced diffusing capacity. However, some patients with relatively little parenchymal abnormalities can have a reduced DLCO. It's a hard thing to follow over time. If somebody obviously valsalvas during the DLCO maneuver, that can increase their DLCO falsely. If they smoke a cigarette right before they come in, it can affect it. If they're sitting in traffic for a long time and breathing in exhaust, that can affect it. Or if they have heart failure, a lot of other things can affect DLCO. However, the take-home point is that if you ever see somebody whose FVC is 80%, and their DLCO is 30%, any reduction in DLCO out of proportion to FVC, as they say, really should prompt clinicians to be thinking about pulmonary hypertension. The other things that we do is actually test inspiratory and expiratory muscle strength, because you can get respiratory muscle involvement. And then pulmonary hypertension will often follow a 6-minute walk testing. And a lot of these people will have pretty profound exertional hypoxemia. I had a patient in clinic with me on Monday who was 95% on room air. As soon as you start walking, though, he needs to be on 6 liters to maintain his sats at 90%. So really profound diffusion deficits in patients with pulmonary hypertension. And as I mentioned earlier, pulmonary rehab, it's good for everybody. If it were up to me, I would somehow create a program that would pay for it for every sarcoid patient for the rest of their life. So why is sarcoidosis different? The hard thing for patients, and I should say, maybe I should call it the psychology of sarcoidosis, is that externally, they may look totally normal. But they may be completely short of breath, despite having normal breathing tests. They may feel completely fatigued, like they can't get anything done, and it's legitimately due to their sarcoidosis inflammation. But again, on the outside, they look normal. And so talking to family and friends, when they're complaining about symptoms and they look normal, oftentimes it doesn't garner much sympathy. And obstructive lung disease is different in sarcoid than COPD. A lot of people, they'll come in and say, they told me I had asthma for a year and then finally did a biopsy and then I ended up having sarcoid. And so oftentimes when we see patients whose picture just doesn't really fit with asthma or COPD, sarcoid should be definitely considered. It can affect anyone. The 9/11 first responders are a great example of that. And the other issue with sarcoid is there aren't really any good resources out there. any sort of education or insight that you guys can provide, as you move forward in your careers and are seeing a lot of people potentially with sarcoidosis, don't tell them to Google about sarcoid, because half the stuff you read on there is not true. The Foundation for Sarcoid Research is good. We have some educational material on our website. But the people who Google sarcoid, they get a lot of discrepant information. So even on the NIH's website about rare diseases, they have an asterisk that says not a rare disease. The World Trade Center website says causes symptoms that are usually not disabling, but regardless of the kinds of symptoms you have, your life will probably be relatively normal. And so when you look at how some places describe treatments, it goes all the way from you only need treatment for a short time and heals without treatment. But in rare cases, sarcoidosis damage is severe enough that lung transplant or pacemaker implantations needed. And obviously corticosteroids are not a good thing, which is what we tend to treat people with first. There are a lot of other second and third line drugs out there now. So if you ever talk to anybody that says, hey, I've been on 20 milligrams of prednisone for the last 2 years, send them to somebody who knows how to manage sarcoid, because I always tell patients, if you're still on high-dose prednisone in the next 6 months, then I've failed at doing my job of, getting you on the right medicines. And there's just, innumerable examples of, false information out there. This Marshall protocol, this is a physician who basically came up with this combination of medicines that he thinks works and has testimonials from patients, but he's not willing to actually do a trial using his medication combination. It's proprietary. You have to pay him through his website for him to send you these medicines. And so there's a lot of sort of suspect ideas out there, which unfortunately happens in rare diseases when there's not a lot of other data that you can make strong arguments for. So obviously our website, any information you need can be on there, as well as links to FSR and other places. We do have support group meetings quarterly for patients as well, which is important. A lot of these people feel like they're living in a bubble, but in reality, there's a lot of patients out there that they can have a community with. And so hopefully you got something out of this today to be able to spread the word. What questions do you guys have?
Dr. James, as respiratory therapists who are seeing these patients on the front line, what can we do early on to help unmask the sarcoidosis patient? Because they're being treated as an asthmatic or being treated as a COPD patient. How can we help facilitate this conversation with some of the primary care physicians that we're dealing with?
So I think a lot of that, obviously it may be hard, depending on the ego of the physician, to go up to them and say, hey, have you thought about sarcoid? But, I think asking the patients about it specifically may be the best way to sort of essentially give them information to help advocate for themselves. If you've got a good relationship, with the ordering physician, then, at least me personally, I don't know that any of my colleagues would be offended by anybody coming up and saying, hey, do you think there's a chance this person could have sarcoid? Sometimes it's obvious, so lupus pernio that I mentioned earlier is a real disfiguring skin lesion on the nose. That's one of the few things you can look at somebody and say, oh, wow, do you have sarcoidosis? And the other thing is, in tattoos, people can actually get something called scar sarcoidosis, where they get raised bumps in their tattoos. And that's also really specific to sarcoid. So certainly if you see anything like that, that would be something where you go up to the doctor and be like, hey, this guy's got, what looks like lupus pernio. Do you think they could have sarcoid? But I really think most people just don't know about it, especially, patients who don't know anybody with sarcoidosis. And so just, saying the word sarcoidosis a lot of times can get the ball rolling. And, in a perfect world, physicians would be open to suggestions from anybody. But I don't want to promise you that's how it is. Oh, Sorry, I can't hear you.
There we go. Does anybody here have a question for Dr. James, maybe about a respiratory care plan or something specific that you might have maybe back in your area where you work? So I know many of y'all are doing pulmonary functions or associated with that. Okay. Well, Dr. James, I do really appreciate you doing the presentation for us today. I know that when I saw you speak at the state conference, it really did open my eyes up to how we have to get this information out there and start thinking about not just doing our PFTs, not just treating our patients, start thinking maybe it's a little bit more than just COPD. Maybe it's a little bit more than just an asthmatic that I'm giving a breathing treatment to.
Exactly. Yeah. It's definitely needs to be on the list for everybody to be thinking about. So I appreciate the opportunity to do it and happy to answer any questions in the future if anything comes up.
Thank you so much. If there are no other questions, we don't want to hold you up. We know that you're very busy. We appreciate you taking time to support our program here at Newberry College. And hopefully you'd be willing to come back and speak again to our future groups, because we want to help get the word out.
Yeah, absolutely. Happy to.
Thank you so much.
All right. Y'all take care.
Thank you so much.
Have a good one.
Thank
Have a
you.
great day.
Bye.